Pancreas, presented by Dr. Aaron Shavinsky. Please give a warm welcome back to Dr. Shavinsky.
Thank you all for your kind indulgence during the last lecture, understanding that everything that I said will probably be untrue by the time I get home this evening. But the rest of the lectures, I think, will be less controversial and a little bit more general agreement on. So we're going to talk now about management of pancreatic diseases and pancreatic cancer. So we'll move forward with that. Again, nothing new with my disclosures. We're going to talk a little bit about the anatomy of the pancreas, a few of their congenital abnormalities, some pancreatic physiology, talk about the management of acute and chronic pancreatitis, including the surgical management, management of pancreatic cancer, the management of cysts, pseudocysts, and IPMN, and finally, a little bit about trauma. Now, did your trauma talk at all about pancreatic trauma?
Yes,
a little bit. Okay. So we're not going to delve too deeply in it. Hopefully, it'll be consistent. So, first question. You're exploring a 75-year-old jaundiced white male with a suspicious mass in the head of the pancreas. While transecting the pancreas in preparation for performing a Whipple procedure, what anatomic anomaly must you be concerned about? Bifid portal vein, replaced right hepatic artery, accessory spleen, accessory right hepatic duct, or pancreas divisum? And the answer is B, a replaced right hepatic artery. And the answer is that a replaced right hepatic artery, which branches from the superior mesenteric, will often go through the head of the pancreas as it tries to reach the liver. So you always have to be cognizant of that as you look at your preoperative imaging study. And oftentimes you can ligate it without really any serious damage or reconstruct it if you need to. So, a couple of words about the pancreas. The pancreas, retroperitoneal organ, lies behind the stomach, forms the posterior wall of the lesser peritoneal sac, crossing the vertebral bodies at L1, just inferior to the origin of the celiac artery. And that's very important because as it crosses the spine, it's the area where it tends to get injured by a steering wheel in a mid-abdominal crush injury. And when you fracture the pancreas, you fracture it right at that level over L1 as it crosses the spine. Anatomically, we divide the pancreas into the head, uncinate process, body, and tail, although there's no absolute anatomical differentiation between those. We know that the uncinate process is the part that hooks around behind the superior mesenteric artery and superior mesenteric vein. The head is the part between the uncinate process and the body. The body and head differentiator is right over the vessels. There is really no clear-cut anatomical boundary between the body and the tail. It's just sort of where you think it ought to be, but there's no clear-cut anatomical guideline. The important relationship is that the celiac artery is right beneath it, and that the superior mesenteric artery and vein tunnel right in that hook as it hooks behind that area. And here we see a replaced right hepatic artery coming up from the superior mesenteric up in through the pancreas and into the liver. And here you can see that on CT. So the arterial supply of the pancreas comes from both the celiac and the SMA. The anterior and posterior superior pancreatico-duodenal artery, which is branches of the celiac from the gastroduodenal, also supplying the duodenal sweep. The anterior posterior inferior pancreatico-duodenal comes from the SMA. The dorsal pancreatic is a branch of the splenic. The splenic artery runs along the superior border of the pancreas, and an anomalous right hepatic may branch from the SMA and course through the pancreatic head. And here we see again the stomach reflected up, where you have the celiac right here, and you have the splenic coming right across the top, the hepatic and the gastric coming up. The venous drainage is through the pancreatico-duodenal vein, drains the pancreatic head and duodenum, drains into the gastroepiploic and portal vein. You have the splenic vein, which drains the inferior mesenteric vein, and then the transverse pancreatic vein, which drains the body and tail. And the most important relationship, of course, is that the splenic and the superior mesenteric vein join together to form the portal vein directly beneath the neck of the pancreas, that area that divides the body from the head. The pancreatic duct, the main duct is the duct of Wirsung, drains the entire pancreas from tail to head, lies in the gland, more posterior than anterior, and joins the common duct terminating at the ampulla ovata. The duct of Santorini, or the minor duct, drains the anterior superior portion of the head. It may empty into the duct of Wirsung or terminate in the duodenum into a minor papilla. And when it terminates in the minor papilla, it can be one of the associated causes of surgically correctable chronic pancreatitis when you have stenosis of the minor papilla. And here we see the typical. Here we have the main duct, and here we have the accessory duct, the major papilla and minor papilla. A little embryology. The dorsal and ventral pancreatic buds develop and fuse. The dorsal becomes the head, body, and tail. The ventral becomes the uncinate process. The acini and the islets are seen during the 4th month of development. And remember that the islets are neural crest cells that migrate from the neural crest into the pancreas and are not ductal in origin. Question. A neonate has been diagnosed with an annular pancreas after presentation with postnatal nausea and vomiting. The preferred method of correction is A, division of the pancreas blocking the duodenum. B, endoscopic papillotomy of the minor papilla. C, distal pancreatectomy and splenectomy. E, duodenojejunal bypass. Or E, Whipple resection. And the answer is D, duodenojejunal bypass. You want to avoid dividing the pancreas as you might divide the pancreatic duct. So annular pancreas is incomplete migration of the ventral bud, where the pancreas encircles and obstructs the duodenum, often associated with duodenal atresia. Complicates 1 in 12,000 to 15,000 births, presents with abdominal pain and jaundice, 1/3 presenting during the first year of life. And the treatment is duodenojejunectomy bypass. Avoid dissecting or resecting or dividing the gland, as you may divide the pancreatic duct. Pancreas divisum, present in 5 to 10% of all people, is more common in women in the 3rd and 4th decade. It's diagnosed with ERCP. It's where the duct of Santorini is abnormally large and draining separately into a minor papilla. You may have an absent or vestigial duct of Wirsung, and it may cause acute, recurrent, and chronic pancreatitis. The treatment is open or endoscopic papillotomy of the minor papilla. Which of the following is not true regarding pancreatic exocrine function? Secretin is a strong stimulator of water and bicarbonate. Cholecystokinin is a strong stimulator of enzymes. Somatostatin shuts off exocrine secretion. Amylase and lipase are secreted in an inactive zymogen form requiring acid to become effective, or trypsin and chymotrypsin are secreted in an inactive zymogen form requiring acid to become effective, which is not true. And the answer is D. Amylase and lipase are not secreted in an inactive zymogen form, but they're actually released in active form as opposed to trypsin and chymotrypsin. So a few words about physiology of the pancreas. 1.5 to 2.5 liters of pancreatic juice produced daily. It's colorless and odorless. It has a basic pH. The only other body fluid that has a basic pH is saliva. It's isoosmotic with plasma and secreted by acinar and ductal cells in response to the use of secretin. Bicarbonate transport, active transport exchanging chloride for bicarbonate, and carbonic anhydrase catalyzes that reaction. 1 to 3% of the pancreatic juice is protein, 90% of that is enzymes. Amylase and lipase secreted in active form, trypsin, chymotrypsin, and carboxypeptidase in active zymogen form that usually requires acid to become effective. The exocrine function, neural response, acetylcholine from the vagus stimulates enzyme secretion. CCK or cholecystokinin strongly stimulates enzyme secretion and weakly stimulates water and bicarbonate, whereas secretin and VIP, vasoactive intestinal polypeptide, weakly stimulates enzymes and strongly stimulates water and bicarbonate. Pancreatic polypeptide, somatostatin, and glucagon inhibit the exocrine flow, and in fact somatostatin used pharmacologically shuts down both endocrine and exocrine function in the pancreas and is used pharmacologically to cut down on pancreatic fistulas as well as pancreatic endocrine tumors. So the islets of Langerhans are the endocrine cells. Alpha cells are 20% and they secrete glucagon. Beta cells, 75%, and they secrete insulin. The delta cells make somatostatin, the D cells, gastrin, and pancreatic polypeptide, and they're involved in blood glucose metabolism. Remember, they don't empty into the duct, they empty into the circulation. So, a couple of words about pancreatic endocrine tumors, of which they like to ask on the exam. Insulinomas are insulin-producing tumors of the beta cells. 10% are malignant. They may be multiple. They present with Whipple's triad, spontaneous episodic hypoglycemia, neuroglycopenic symptoms, and relief of symptoms with glucose. You localize them by CT, MR, angio, or intraoperative ultrasound, and the treatment is generally enucleation if they are benign. Streptozotocin or diazoxide for unresectable metastatic or recurrent insulinoma, and somatostatin palliatively turns off all pancreatic endocrine secretion. So if you ever have that question is, what do you treat metastatic endocrine tumors? It's always with somatostatin because it shuts down the endocrine production. Glucagonoma presents with necrolytic migratory erythema, diabetes, glossitis, anemia, and weight loss. It begins in the alpha cells, 80% or more are malignant. Resection is the primary treatment, and again, somatostatin palliative reduces that. There was a question on this on one of the more recent exams as well, just for you to know. Gastrinoma is a ZE syndrome, Zollinger-Ellison syndrome. It's a G cell tumor of which 60% are malignant. All of the endocrine tumors, with the exception of insulinoma, are more than 50% malignant. The only one that's less than 50% likely to be malignant is insulinoma. All of the others have a much higher rate of malignancy. There's marked basal gastric hyperchlorhydria. which can be diagnosed either with a calcium or a secretin stimulation test. There's markedly elevated serum gastrin, and you diagnose this by having acid in the stomach and circulating gastrin level. So if you do an endoscopy and aspiration, and you have acidic content in the stomach, and you have circulating gastrin, that's pathognomonic, because you shouldn't have circulating gastrin with a hyperacidic stomach, unless you've had a retained antrum or something like that, post-gastrectomy, which is another story. The primary tumor is in the gastrinoma triangle, which is bordered by the cystic duct, the head of the pancreas, and the third portion of the duodenum. So they can be in the duodenum or in the pancreas. It used to be total gastrectomy was a palliative option. Now with the better H2 blockers and other blocking agents, as well as with somatostatin, it's unlikely to be required. The use of octreotide or sandostatin, which is the pharmacologic equivalent of somatostatin, has been used successfully in reducing the need for gastrectomies in these patients. WDHA, or Werner Morrison syndrome, watery diarrhea, hypokalemia, achlorhydria, are tumors of VIP, PPP, GIP, and secretin. They begin in the type 4D1 cell, 5 to 10 liters of potassium-rich diarrhea daily. Most are malignant, and most are metastatic at diagnosis. The treatment is resection if possible. Palliative treatment with streptozotocin and diazoxide, and again, somatostatin analog palliatively reduces the endocrine flow. Moving on to the treatment of pancreatitis. 32-year-old alcoholic male presents to the ER with nausea, vomiting, and epigastric pain. He is diagnosed with pancreatitis. Which of the following is not one of Ranson's criteria, which can help you decide on the severity of the attack? Calcium level of less than 7 on admission, arterial PO2 of less than 60 at 48 hours, LDH greater than 350 at admission, fluid sequestration of greater than 6 liters at 48 hours, age over 55. So which is not one of Ranson's criteria? And the answer is A, and we'll go through Ranson's criteria in just a moment. So, acute pancreatitis, generally due to either alcohol or biliary tract disease, can be due to postoperative cases, trauma, can be due to ischemia, can be due to toxic medications, most commonly the thiazide diuretics, can also be due to hyperlipidemia. Alcohol may be a direct toxin to the gland, increasing precipitation in ducts, increasing pressure at the sphincter of Oddi, and it's the most common cause of pancreatitis in urban hospitals. Gallstones passing into the common duct, causing obstruction of the common channel, where bile is thought to activate the pancreatic enzymes, is the most common cause in suburban hospitals. And here we see the stone impacted at the distal common duct, which is one of the causes of pancreatitis. Presentation of pancreatitis, mid-epigastric pain, often radiating to the back, nausea, vomiting, and retching, upper abdominal tenderness and guarding, fever, tachycardia, and leukocytosis, jaundice, anemia, and hypocalcemia. It's diagnosed with an elevated serum amylase and lipase, but that can also be found in other conditions. CAT scanning is the study of choice. An abdominal x-ray may show either a sentinel loop or a colon cutoff sign representing a local area of ileus. And here we see the boggy, swollen pancreas. Here we can see an ileus, colon cutoff sign representing inflammation in the retroperitoneum and the lesser sac. So here are Ranson's criteria. I mention them because they come up from time to time. There are 11 altogether, 5 at admission, 6 after 48 hours. So at admission, age less than 55, white count greater than 16, age greater than 55, white count greater than 16, glucose over 200, LDH over 350, SGOT greater than 250. And then after 48 hours, hematocrit fall of more than 10%, rise in BUN of over 5%, calcium of less than 8, PO2 of less than 60, base deficit more than 4, fluid sequestration greater than 6 liters. And you see that the mortality risk is associated with the number of Ranson's criteria, but also note that this is much more predictive of the mortality in alcoholic rather than biliary tract pancreatitis. So this really doesn't predict well the biliary tract pancreatitis mortality as well as it does for alcoholic pancreatitis. Therapy of acute pancreatitis, supportive therapy, NG tube plus minus, aggressive hydration, electrolyte repletion, ventilatory support if necessary, pain control, monitoring of urinary and central venous pressures, urinary output, and ICU. Antibiotic use is reserved only for acute hemorrhagic pancreatitis, and when used, it should be imipenem silastin, which is the effective drug for acute pancreatitis. Surgical indications for acute pancreatitis, treatment of the complications, uncertainty of diagnosis, the management of cholecystitis and choledocholithiasis, progressive clinical deterioration, the management of pseudocyst and pancreatic ascites, and the prevention of recurrence in surgically correctable cases like in pancreas divisum. Surgical indications, when to do a cholecystectomy. It's currently recommended that for acute biliary pancreatitis that the cholecystectomy be performed at the time of the first admission if the patient is stable enough, after the enzymes have begun to normalize, and that the duct needs to be evaluated either by preoperative ERCP or intraoperative cholangiography, even though the chance of there being a residual stone is probably 10% or less. Early ERCP is indicated if patients are deteriorating and failing to resolve, as they tend to do quickly after the initial attack. Management of pancreatic abscess, which is rare. The mortality is 100% without drainage, 30 to 50% with drainage. They usually present with fever and leukocytosis about 1 to 2 weeks after the initial attack. You may see gas bubbles or fluid in the area of the pancreas. The appropriate treatment regimen is to do a biopsy of that area under CT guidance and look for bacteria and send it for culture. And if it does show bacteria or if the patient worsens, then surgical debridement, necrosectomy, and washout is appropriate. And here we see kind of the pancreas with little gas bubbles and air fluid levels and a necrotic pancreas. Chronic pancreatitis, typically from alcohol, but can be due to other things: idiopathic, tropical, hereditary, hyperparathyroidism, pancreas divisum, pancreatic ductal obstruction, autoimmune pancreatitis, or cystic fibrosis. The pancreatic duct obstruction is caused by strictures and stones. Increasing intraductal pressure during pancreatic stimulation causes pain. Continued obstruction and fibrosis leads to acinar atrophy and pancreatic insufficiency, sclerosis with destruction and permanent loss of exocrine function, and they may be focal, segmental, or diffuse. The ductal dilatation and strictures are common with plugs and stones in the duct. The symptoms: recurrent abdominal pain, steatorrhea, weight loss, diabetes, exocrine insufficiency, malabsorption, commonly cysts and pseudocysts, which can be infected or non-infected and may communicate with the main pancreatic duct or not. Autoimmune pancreatitis is an hyper IgG4 disease associated with the antiphospholipid syndrome, which does respond to steroids. Type 1 It's older, and they're prone to relapse. Type 2 is younger and self-limiting. It's difficult to distinguish from pancreatic cancer. They often present with painless jaundice. CT shows a diffusely enlarged pancreas. ERCP shows a diffuse irregular narrowing of the main pancreatic duct, stenosis of the intrahepatic bile duct. It's associated with other autoimmune disorders in the Japanese classification. Pancreatic imaging shows diffuse narrowing of the main duct with a regular wall, more than 1/3 of the length. Laboratory data demonstrates abnormally elevated serum gamma globulin, IgG, or autoantibodies. And histopathologic examination shows fibrotic changes in lymphocytes with plasma cells. Generally speaking, these are treated with steroids, not with surgery, but some may come to surgery due to the failure to be able to differentiate between this and a cancer. The radiology of chronic pancreatitis, in about half the time you'll see calcifications. Most of the time you'll get CT ultrasound or endoscopic ultrasound, which can show calcifications, gallstones, dilation of the pancreatic duct. And dilation of the pancreatic duct is the major branch point as to the determination of what type of procedure to do if you're going to contemplate surgery on these patients. ERCP to look at the anatomy to rule out cancer, for recurrent pain, and to look at a pancreatic duct leak, pleural effusion ascites, or a pseudocyst. And here we see the typical chain of lake configuration on ERCP. Here we see kind of a shrunken pancreas, and here we see the pancreatic calcifications. Complications of chronic pancreatitis: pain, abscess, pseudocyst and fistula, jaundice, obstruction, hemorrhage, or malnutrition. The treatment, first and foremost medically, stop drinking if they're drinking alcohol, limit dietary fat, feed with medium-chain triglycerides, frequent small meals, exocrine replacement, celiac block for pain, analgesics, and about half of the patients will be benefited by endoscopic therapy, including sphincterotomy, stone extraction, and stenting. What are the surgical indications for chronic pancreatitis? Intractable pain, large or multiple pseudocysts, common duct, duodenal, or colonic obstruction, portal vein obstruction with portal hypertension, splenic vein thrombosis and sinistral varices, pancreatic fistulas or ascites, the inability to exclude cancer, and the presence of these with a dilated pancreatic duct. So, this is probably the most important slide in this set, and that is the determination of what to do, surgically what to do, for a patient with chronic pancreatitis hinges completely on whether the pancreatic duct is dilated or not dilated, and that's over or under 6 millimeters. If they have a dilated duct, they'll get a bypass type procedure, and they'll have a very high chance of success and pain relief. If they have a non-dilated duct, they're going to get a resective procedure. They're going to end up with brittle diabetes, and more likely than not will not have a good outcome regarding pain relief. Just to remember. So a dilated duct, most often they'll get a Cousteau procedure, Roux-en-Y lateral pancreatic jejunostomy. They can also get a Fry or a Beggar procedure, which can go for both of these, which is the Fry is a subtotal ventral head resection and drainage. The Beggar is a duodenal preserving pancreatic head resection. That can be done for both dilated and non-dilated ducts, but the Cousteau is limited only to those with a dilated duct. Resections, Whipple, or total pancreatectomy, or some type of nerve resection procedure, but generally not a very good outcome. So, pancreatic jejunostomy, intractable pain with dilated pancreatic duct, chain of lake configuration, pancreatic fistula where the source of the fistula can be incorporated into the anastomosis, or a pseudocyst with communication to the main pancreatic duct. Midline abdominal or subcostal incision, enter the lesser sac, wide Coker maneuver, mobilize the right colon, identify the duct, which is usually bulging through the anterior surface of the pancreas, and you can use ultrasound or a needle to identify the duct. Fillet the entire duct from head to tail, both Wirsung and Santorini, and then lay a jejunal loop over it. The general reason that these fail is that you fail to carry the dissection far enough onto the head to deal with all the strictures. You want to biopsy any suspicious areas, remove all stones, and drain all cysts. Construct a roux limb of 50 to 60 centimeters. Construct the anastomosis to the pancreas, biliary tract, or to the pseudocyst. About 40% are pain-free, 40% are improved. Low mortality rate should be expected. And here you see the Pousteau, where you're filleting open the pancreatic duct, and then you're constructing a roux limb that lays right along the pancreas. Resective procedures for those with intractable pain without ductal dilatation, subtotal or total pancreatectomy, Fry procedure if it's limited to the pancreatic head, or a Beggar procedure with duodenal producing pancreatic head resection. These all have high failure rates, high recurrence rates, high complication rates, high rates of diabetes, and no better than 50% initial and 20% long-term. The exception to that is if you have isolated left-sided chronic pancreatitis, a distal pancreatectomy and splenectomy is generally curative. So here we see a Fry procedure where you're coring out the head of the pancreas and then filleting open the duct. And here you see a Beggar procedure where you're actually removing that segment and draining the tail and the head into a loop of jejunum. These are pictured because you should know about them. They're not commonly done, and they don't generally have a great success rate. Total pancreatectomy or Whipple procedure, again, rarely done for chronic pancreatitis. Usually when you can't distinguish between pancreatitis and cancer, in somebody who may not be an alcoholic, who presents with isolated biliary obstruction and pancreatic ductal obstruction, you do a Whipple on them and it turns out it's pancreatitis. You tell them to go out and celebrate that they don't have pancreatitis, they don't have pancreatic cancer, and that they should do very well. So, Whipple, multiple cysts or calcifications in the head, biopsies, biliary or duodenal obstruction, portal vein compression, inability to exclude cancer. Mortality rate should be under 5%. 20% will become diabetic. About a 70% initial success, 50% long-term. Again, depending on whether they decide to stop drinking or reform whatever habits might have caused the pancreatitis. Moving on to pancreatic cancer. When performing a pancreatic duodenectomy for a jaundiced patient with a 2-centimeter mass in the head of the pancreas, all of the following are contraindications to proceeding with curative resection except a 1-centimeter peripheral left lateral segment metastasis, which is easily resectable, encasement of the SMA, intraoperative biopsy revealing only pancreatitis, celiac area nodal involvement, or a small unresectable omental implant. All right, so the correct answer is C. Any metastasis out of the region is considered unresectable, even if the tumor is technically resectable. So that certainly applies to lesions in the liver, lesions in the omentum. The celiac, you might be able to make an argument to do a celiac node dissection, but generally most people would consider celiac nodal disease to make that an unresectable or at least incurable lesion. So roughly 49,000 new cases, 40,000 deaths in 2015 for pancreatic cancer, equal male and female predominance, average age of onset at 60 or beyond, often associated with diabetes, smoking, alcohol consumption, familial pancreatic mutations, including 90% mutation for KRAS and P16, 50% HER2, P53, and DP54, 10% for BRCA2. The recent onset of diabetes seems to be a risk factor for the development of pancreatic cancer, meaning that if you go back and look at diabetes developing within the previous 6 months in pancreatic cancer patients, you'll see a higher predominance. Signs and symptoms: vague pain radiating to the back, anorexia and weight loss, jaundice if the tumor is in the head or the uncinate process, new onset of diabetes, new onset of venous or arterial thrombosis, or so-called Trousseau's sign. Generally, you'll do a CT or an ultrasound. An ERCP will show a double duct sign. Endoscopic ultrasound or transhepatic cholangiogram. Biopsy can be done. The tumor markers that are usually monitored are CEA and CA19-9. So here we see the classic double duct sign with dilation of the common bile duct and the pancreatic duct. Here we see the tumor on CT. And this is just one algorithm, not certainly the only one. You have a pancreatic tumor, you do a contrast CT. If they're metastatic, you do a fine needle aspiration and they go on to therapy with chemotherapy. If they have localized disease, you see a mass on CT which is resectable, they'll go on to resection. If it's unresectable, you'll get a biopsy and go on to therapy. If you don't see a mass on CT, then they'll get an ERCP or an endoscopic ultrasound, and then if they're resectable, go on to resection. This is by far and away not the only way to do it, but one very common way to deal with this. A couple of lessons. One, you don't really need preoperative biliary drainage if you're going to go on to surgery quickly. It increases the infection rate if you do go ahead with biliary drainage, more if you do an external biliary drainage than internal drainage. You almost always will do a laparoscopy to assess for metastatic disease prior to definitive resection. Whipple pancreaticoduodenectomy cure rate about 5 to 10% at 10 years. Ampullary duodenal and common duct cancers maybe 25 to 40%. Mortality for the procedure should be under 5%. Morbidity 30 to 40%. The cancer diagnosis is not essential to resection, and the proper patient presenting with the proper set of guidelines and the proper radiologic images that you do not need a preoperative biopsy to go ahead with resection. Postoperative chemoradiation is used for node-positive patients, patients with positive margin. Typically, the current regimen uses gemcitabine and 5-FU. Some people will use a taxane as well. And add to that also. So what's the definition of resectable? As I tell my residents, resectability is a state of mind. Everything is resectable. It's a matter of what you have to give up and what the risk is in doing it. So how do you define resectability in pancreatic cancer? And this is a consensus conference from the American Hepatobiliary and Pancreatic, Hepatobiliary Pancreatic Association and the SSO Combined Consensus Conference. So a resectable pancreatic head lesion shows no extension to the celiac, common hepatic, SMA, with a portal vein SMV complex that's open and characterized as stage 1 or stage 2, T1 to T3, NXM0. Locally advanced is defined as where you have encasement of the SMA of more than 180 degrees, celiac involvement, occlusion of the SMV portal vein complex, stage 3. And then borderline would be where you have impingement of the SMV portal vein, abutment of the SMA, GDA encasement up to the hepatic, colon or mesentery involvement, and that's stage 3. What does that look like on film? Well, here's a resectable tumor. Here's the tumor. Here's your SMV. You see a nice black line between the tumor and the SMV, meaning there's no involvement. The SMA is free. This would be a surgically resectable pancreatic cancer for which you would go ahead and go on with immediate surgery. Here you have a patient where you don't have that black line between the SMV and the mass. It's partly obliterated. And that patient if you're going to take right to surgery, will likely need at least a partial resection of the SMV or portal vein. And many of these patients will go on to receive neoadjuvant therapy first, prior to resection, in which case you need a diagnosis, in which case they need an EUS and biopsy, or else your oncologist will not treat them. So they'll get preoperative either FOLFIRINOX or gemcitabine GTX, gemcitabine taxotere or whatever the local cocktail is, FOLFOX, FOLFIRINOX, GTX, GAX, possibly preoperative radiation as well. Again, here's another one with borderline resectability. Here's your SMA, and you can see that it's abutting the SMA. The SMV looks pretty clear. This also would be likely recommended for neoadjuvant therapy. And here, where the tumor is within the vessel, or the vessel is within the tumor, they're not likely going to be resectable. So more and more patients are being referred for neoadjuvant therapy these days. It both allows for more cogent and coherent scheduling, and since almost all of these folks will be getting post-operative chemotherapy anyway, you're really not losing anything by treating them and making sure they don't come up with metastatic disease. Yes?
How often do you see these currently non-resectable lesions converted to a theoretically resectable lesion with the neoadjuvant treatment?
About 10 to 20%. More with the this and this, you'll have a much higher rate of conversion than this. This is going to be rare. And of course, the old, can you get your finger under it or not? That's the ultimate defining resectability or not resectability. Now, some of the studies that have been published, and particularly those, for example, out of Columbia University, when you look at their study, almost 40% of their Whipples are done with vascular reconstruction. And that begs the question is, philosophically, is that really going to benefit the patient or not? And if you have to do a vascular resection, is that really a patient who's ultimately going to benefit? And I think the jury's still out on that. I think that if you're doing 40% vascular reconstructions, that's a lot. Just my opinion. So here you have your pancreas reflected with a generous Coker maneuver, your SMA and SMV visible here. And the typical Whipple, and there are many ways to do this. This is just one way. It's the way I like to do it. It by no means is the only way to do it. There are some people that do a Roux-en-Y. There are some people that do a lateral, but generally speaking, for a traditional standard Whipple, gallbladder, common duct, antrum, entire duodenum, up to the jejunum is removed and reconstructed in some way, pancreas to jejunum, bile duct to jejunum, stomach to jejunum, whether you do this end to side or end to end, whether you do a direct duct to mucosal anastomosis, whether you stent it, whether you do a Roux-en-Y, whether you do a pylorus preserving or not. Those are all really technical details that are probably less likely to show up on your exam. And again, this is the way I tend to reconstruct them, just because that's the way I learned to do them and it's worked for me. What are the margins of importance? The biliary, pancreatic neck, soft tissue, and retroperitoneal. There's lack of uniformity, but I will tell you that the studies of neoadjuvant chemotherapy have demonstrated that you get a much higher rate of margin negativity after neoadjuvant therapy. So it is important in those borderline cases. Ampulectomy is for tumors of the ampulla. Some benign and small malignant tumors can be removed by endoscopic mucosal resection or surgical ampulectomy. Reconstruction of the common duct and pancreatic duct through transduodenally may be required. But many of the more advanced endoscopists are comfortable doing endoscopic mucosal resection of the ampulla. They usually stent both the pancreatic and common bile duct first, prior to that, in order to maintain their continuity. Survival of pancreatic cancer. If you look at some of the larger studies, 329 patients, multidisciplinary approach, 92% Whipple, 1/3 had vascular reconstruction. 5-year survival, 27%. Median survival, 24 months. Another study, 5-year survival, 19%. Probably the largest study, the Johns Hopkins study, 1,400 patients undergoing Whipple over a 36-year period. Median age 66, 42% with positive margin, 78% positive lymph nodes, perioperative morbidity 38%, length of stay now about 8 days, mortality about 1% now, 5-year survival 18%, median survival 18 months, probably at the mecca of pancreatic surgery at Johns Hopkins, or at least as they would have you believe. 20% survival and a 40% positive margin rate. So palliative treatment, stenting, bypass. If you're going to bypass to the common duct, not the gallbladder, because it tends to obstruct. Gastrojejunostomy should be added, as there is about a 20% risk of subsequent duodenal obstruction, and palliative chemotherapy with the drugs as listed. Moving on to cysts and pseudocysts and IPMN. This is an area probably has the most controversy of all of the things I'm going to talk about. So, when evaluating a patient for a cystic pancreatic neoplasm, which of the following would not lead you to recommend surgery? Size over 3 centimeters, presence of mucin in the aspirate, cyst fluid CEA over 200, high serum amylase, or presence of abdominal pain. This question may very well appear on your exam because they like questions about pancreatic cysts. When I say that, I'm not writing questions for the boards because you can't do this and do that. So you got to pick one or the other. And that's correct. A high serum amylase would not lead you to doing surgery, but a size over 3 centimeters, mucin in the aspirate, a cyst fluid CEA over 200, or symptoms of pain would lead you more toward resection than not in patients with cystic pancreatic tumors. So, we're going to talk about pancreatic cysts. We are not going to talk about true cysts because they're rare. We're going to talk a little bit about parasitic cysts and about cystic tumors and pseudocysts. So, about 75% of pancreatic cysts are pseudocysts due to prior pancreatitis or trauma. Cystadenomas and cystadenocarcinomas present similarly. They're slow growing with few early symptoms, often found serendipitously on CAT scan or ultrasound, mostly in middle-aged women. Resection after discovery is usually recommended, and for cystadenocarcinomas, cure rates approach 70%. So it's a much different animal than solid pancreatic tumors, and the cure rate and the survivability is much higher. So here we see a pancreatic cystic lesion of the head and of the body with a dilated duct. So the diagnostic evaluation for pancreatic cystic tumors is usually a triple phase CT with an arterial and portal vein phase, looking for septations or mural nodules, endoscopic ultrasound with cytology and sampling for CEA, serum CEA and CA19-9. About 10 to 15% will harbor carcinoma in situ or invasive cancer. This is higher in the mucinous tumors or with high cyst CEA levels, and these can be done open laparoscopically or robotically, particularly if they're distal. IPMN, or intraductal papillary mucinous neoplasm, is present in about 1/4 of all resected pancreatic tumors. This is really carcinoma in situ of the pancreas, or precancerous, sort of like atypical ductal hyperplasia of the breast. They range from hyperplasia to malignancy. They're slow growing. They tend to be in older individuals. They tend to have mural nodules, elevated cyst CEA fluid, and mucin. There are main duct type, branch duct type, and mixed type. The main duct type is within 1 centimeter of the duct of Versung. Branch duct is in the head in the uncinate process. The main duct type, and this is important, put a star on this, because this may come up on the exam. Main duct type is the one most associated with cancer, and if you have main duct IPMN, that in and of itself is a surgical indication. You can have dysplasia, carcinoma in situ, or invasive cancer. They're prognostically better than solid pancreatic tumors, treated by either Whipple or distal or total pancreatectomy. It's important to get clear margin. With dysplasia or CIS, a 5-year survival near 100%. With cystic carcinoma, about 70%, about 50%. And again, there are multiple mutations within this area. There's PAN1A. PAN is pancreatic intraepithelial neoplasia, which is DCIS of the pancreas. PAN-IN1A, PAN-IN2, PAN-IN3, and then adenocarcinoma. So there's a sequence from pancreatic intraepithelial neoplasia. 1A is the most benign, 2, and then 3, and then ultimately invasive cancer. And it goes through a series of mutations, and there are many genes associated with this rite of passage, including KRAS, which is the most important one, and also P16, which is the other important gene. Pseudocysts. They're a collection of pancreatic juice outside the normal ductal system, encapsulated by a fibrous membrane without an epithelial lining. So the difference between a pseudocyst and a cyst is the epithelial lining. A pseudocyst lacks an epithelial lining. It's caused by rupture of the pancreatic duct or necrosis. Half of them remain connected to the pancreatic duct, which is important in determining treatment. It's the most common complication of chronic pancreatitis, and the treatment should include pseudocyst drainage and drainage of a dilated pancreatic duct if one's available. So here you see your pseudocyst. The non-surgical treatment of pancreatic pseudocyst, IR drainage, about a 70% recurrence rate. Aspiration with catheter drainage has a higher infection rate. Transgastric endoscopic drainage by your GI colleague. The cyst must be adherent to the stomach or a duodenum, but there's about a 20% complication rate due to bleeding or infection, and not useful in people with a dilated pancreatic duct. Surgical treatment really determined by, is it a communicating or non-communicating pseudocyst? Meaning, does it communicate with the pancreatic duct or not? So preoperatively, these patients should all have ERCP evaluation. If it's a non-communicating pseudocyst, you can drain it into whatever piece of the GI tract is closest, stomach, duodenum, jejunum, whatever is easiest. If it's a communicating pseudocyst, the recommendation is to drain it into a Roux-en-Y limb of jejunum. I wouldn't drain it into the colon, by the way. You should look at where is it sitting. You should biopsy it to make sure it doesn't have cancer. Needle insertion to confirm the cyst, make at least a 5-centimeter opening, and then suture it to the stomach, duodenum, or jejunum as you see fit. And lastly, we're going to talk a few minutes about pancreatic trauma. I'm sure you've had this before. So, which of the following statements regarding pancreatic trauma is true? The most common area of blunt injury is where the pancreas crosses the spine. Injuries to the pancreas, which are to the left of the SMA, can be managed with distal pancreatectomy and splenectomy. Minor contusions of the pancreas can be managed by drains alone. Expanding hematomas overlying the pancreatic body should be explored to rule out major vascular injury, or all of the above are true. Correct. So 70 to 80% of injuries to the pancreas are due to penetrating trauma. Rarely it's an isolated injury. Blunt injuries fracture the gland as it passes over the vertebral column due to its immobility. Operative trauma can be seen with upper abdominal surgery on the spleen, stomach, or duodenum. And non-operative management, particularly after blunt injuries, is becoming more common. The mortality rate of all comers for pancreatic injury about 20%. They tend to present with abdominal pain, although they may not. They may have signs of bleeding or not. They may have hyperamylasemia in the serum or in the DPL fluid. The study of choice, of course, is the diagnostic CT scan, which may demonstrate the site and severity of the injury. You may not make the diagnosis for several days, and missed injuries can be picked up by finding a pseudocyst weeks to months later. So some blunt and all penetrating injuries require laparotomy. Minor blunt injuries can be observed depending on the stability of the patient and the CT findings. If you're operating, you should evaluate the entire gland, doing a Coker maneuver, opening the lesser sac. Expanding central hematomas need to be evaluated for vascular injury. Drainage is applicable for most contusions and minor disruptions. Distal pancreatectomy and splenectomy for injuries to the body and tail. You can transect the gland with a stapler, some drainage. You can also do a primary repair, although that's rarely done. All areas should be drained. Distal pancreatectomy and splenectomy, again, indicated for injuries to the body and tail with some drainage. And again, these type of injuries would be amenable to a distal pancreatectomy and splenectomy or distal pancreatectomy alone. For pancreatic head injuries, be conservative, drain if possible. Drain if the injury traverses less than half the gland. Evaluate the duct integrity by inspection, cystic duct cholangiography, duodenotomy, and cannulation of the ampulla, intraoperative ERCP, or in transection of the tail and performing a retrograde pancreatogram. If it is injured and the duct is injured, you want to do a Roux-en-Y drainage if the duct is disrupted. Combined pancreatic and duodenal injuries are the most problematic with a high mortality risk. Try to do drainage and pyloric exclusion, attempt to preserve the parenchyma, close pylorus, perform gastrojejunostomy, retrograde and external drainage, feeding jejunostomy. And Whipple is really rarely indicated for pancreatic trauma, only if you have disruption of the pylorus and the common duct. And again, that's all I have. I'm happy to answer any questions.